Topic of the lecture today is complicated UTIs. Before we get into complicated UTIs, we have to know what UTI is. UTI stands for Urinary Tract Infections. To understand urinary tract infections and its types, whether it's complicated or it's not, let's talk about anatomical features. Now, all of this system can be infectious in urinary tract infections or either one of them. It can start from urethra, it can affect the bladder, it can affect the ureters, even it can affect the kidneys. So any infection will lead to urinary tract infection. So in urinary tract infection, pathogens get their entry from here, or it can also be because of a hematogenous spread. Basically, pathogens get their entry from here, they move up their way here into the bladder by urethra. After moving into the bladder, they colonize, or they can colonize here in the urethra. They can colonize anywhere, and then they can move up, cause infection in urethra, which is called cystitis, then move up and cause infection in ureters, and then move up and cause infection in kidneys, which is called pyelonephritis. So these pathogens which get their entry from here, they have basic risk factors. Let's talk about the risk factors before we head into this. Risk factors include multiple factors, multiple variable factors. For example, it can be a patient who's suffering from some kind of kidney disease, and that patient has Foley's catheter put in. So Foley's catheter increases the chance of getting the UTI up to many folds. Or it can be because of any of the drugs which a person is taking, and those drugs are lowering the person's immunity. When the person's immunity is lowered, these pathogens have better chance of colonizing and causing the disease. Next, what's the next risk factor? Diabetes mellitus. Uncontrolled diabetes mellitus has much to contribute towards UTIs. Then what's the next factor? There are multiple other factors, among which the basic factor and the factor we cannot change is being a woman. Women tend to have 50 times more UTIs than men. Because of what? Because of their short urethra. They have a urethra of 4 centimeter. On the other hand, men have a urethra of 25. That's the basic reason for women to basically get what? Cystitis and pyelonephritis. On the other hand, male of those same age groups are going to get either prostatitis or urethritis. So their urethra and prostate is going to get affected in male species basically, and in female, because of the very short urethra, it's going to be either bladder or kidneys. So bladder is going to be cystitis and kidney is going to be pyelonephritis. Now, as we've talked about these risk factors, we've talked about female being the more victims in these conditions. Let's talk about the types of UTI. It's either going to be uncomplicated UTI. What do you mean by uncomplicated UTI? Uncomplicated UTI means that this UTI in female will either be cystitis or pyelonephritis, and in male urethritis or prostatitis, but it does not have any of the comorbidities along with it. Comorbidities like diabetes mellitus, the patient does not have diabetes mellitus. The patient is not immunocompromised. The patient is not taking any immunosuppressant drugs. And the basic one, patient is not a pregnant female, and patient is not a child. Now these are the basic factors which differentiate an uncomplicated UTI from UTI, from a complicated UTI. So we can call a UTI uncomplicated if all of these factors are not present. If the woman is not pregnant, if it's not a child, if it's not a if it's not a diabetes mellitus patient, if it's not taking any immunosuppressive drugs, or the patient is not immunocompromised. Next, we have complicated UTI. So we can call a UTI a complicated UTI whenever these factors are present. Whether it's children, whether it's just a child, it's going to be complicated UTI. Number 2, whether the patient has diabetes mellitus. If the patient has diabetes mellitus, its immunity is already compromised. So diabetes mellitus is a basic risk factor for complicated UTI. Number 3, that whether it's a pregnant woman. In pregnant women, UTIs can lead to the birth of a low weight child. So it's a very basic risk factor for pregnant women. Number 4, all of those factors which will contribute towards the disease, which will contribute to the hematogenous spread of this disease, like sepsis, that will lead to complicated UTI. And afterwards, if there is any structural abnormality of this whole system, it can be abnormality of the ureters, it can be abnormality of the urethra, it can be structural abnormality of the prostate, it can be structural abnormality of the bladder in females, it can be structural abnormality of the urethra. So any kind of structural abnormality goes for complicated UTI. Next on, we have recurrent UTIs. These happen basically in those patients which are taking immunosuppressive drugs, or immunocompromised patients, or diabetic patients, and it does happen in female patients more than male patients. So recurrent UTI is a term which is referred when a patient is getting UTI 3 to 4 times in 6 months, or 4 to 8 times in 1 year period. If patient is getting these recurrent infections up to this mark, we call it recurrent UTIs. Basic reason of UTIs are either it can be asymptomatic bacteremia, which is called ASB. Next, it can be symptomatic. Among the symptomatic, we only get to know about the symptomatic UTIs. Patient will come to you, or patient will present to you with a symptomatic UTI. Because if it's asymptomatic, patient won't even know that this infection exists. So patient won't even come to you, patient won't even bother, and immunity will take care of itself. On the other hand, the patients who are symptomatic, the patients who have developed all of these symptoms, we'll talk about all of those symptoms which patient is going to develop. Among the symptomatic, it's either going to be cystitis, which is infection of bladder. It's going to be prostatitis, which occurs in males, and it can be very hazardous. Next, we have pyelonephritis, which can be basically found in female patients because of their short urethra, 4 centimeter size of urethra, and this also will be symptomatic in nature. So these 3 will present to you with symptomatology. On the other hand, if the patient has urethritis or some mild infection and we don't even know about it, it's going to be asymptomatic bacteriuria, and we won't even know about it, and immunity will take care of itself. Next on, let's talk about the etiology. Let's talk about what factors contribute towards developing this disease, contribute towards developing this pathology. First of all, let's talk about the causative agents. Which agents cause UTI? There's a category of acute uncomplicated cystitis, which means acute uncomplicated infection of the bladder, and the basic organisms which cause acute uncomplicated cystitis are E. coli, or Staphylococcus saprophyticus, Klebsiella, Proteus, Enterococcus, and Citrobacter species. Now, all of these organisms are responsible for an acute infection of the bladder, and it is not complicated. It's not going to be complicated. On the other hand, we have uncomplicated pyelonephritis. Now, pyelonephritis is an infection of the kidney. When renal parenchyma is being affected, the tubules are being blocked. Now, that infection is called pyelonephritis. And it happens because of the infection which ascends its way to the kidneys and causes pathology. But it can also be because of hematogenous spread. So what organisms cause pyelonephritis uncomplicated? E. coli predominantly is responsible for this. And next on, we have complicated UTI. Now, complicated UTI, we talked about complicated UTI as the type of UTI which will lead to more of infections coming into the body, or this infection will propagate and will lead to sepsis, or there's some kind of structural abnormality, or the patient is immunocompromised, or it's happening on a recurrent basis. So it also contains E. coli predominantly. On the other hand, we have gram-negative rods, which cause UTI, which is gram-positive bacteria. Now, all of these are just causative organisms which cause UTI. And among them, we have seen that E. coli predominantly takes the major portion of organisms which cause UTI in the patients. Next one, let's talk about the pathogenesis. That how E. coli or Klebsiella or all of these organisms we just talked about, how these organisms get into our system and cause this pathology. So it's going to be infection, colonization, or elimination. What do you mean by infection, colonization, or elimination? So infection is going to happen. Those organisms are going to get there. Either the immunity is up to the mark, either it's uncomplicated UTI, either it's because of those organisms which do not cause complicated UTI, which do not cause symptomatic UTIs, and they get eliminated. Eliminated by which? Our own immunity. They get eliminated and nothing happens. Patient doesn't even develop symptoms. On the other hand, there's certain type of infections like E. coli. For example, E. coli gets to your bladder, then gets to your ureters, then gets to your kidney and cause pyelonephritis. Now that's going to be symptomatic. So it's going to be infected, it's going to infect the patient, and then it's going to colonize. So elimination happens in either the pathogen is too weak, either the immunity is too strong. These two factors make up for elimination. On the other hand, if the pathogen is too strong and the immunity is too weak, it's going to colonize. So first of all, organism is going to get there to the host and environment will favor it, whether it's immunocompromised environment, whether it's immunocompetent environment, whether it's acidic, whether it's basic, alkaline. Even the pH of urine has a basic effect on it. So let's talk about the pathogenesis, how these organisms get there. First of all, this is our whole system. These are the kidneys, these are the ureters. They get there into the bladder, then we have urethra. First of all, colonization happens at the urethra level. An organism is going to get there. Let's suppose it's E. coli. It gets there, it colonizes there. Maybe it gets eliminated right here. Maybe it doesn't go up. That's where that elimination terms come in. And it's going to be asymptomatic. Patient won't even know that patient has developed UTIs. Next on, if it has colonized completely and it is going to get into your bladder, it's going to penetrate your uroepithelium. When your uroepithelium is penetrated, what happens next? Ascension into the ureter happens. Now, it can cause infection right here. It can cause infection right here in males or in females. Basically, in females, it's going to be cystitis. Uroepithelium is penetrated and infection propagates here and it's called cystitis. More of the female ratio gets affected because of it, because of the short urethra they have, 4 centimeters of it. So, uroepithelium is penetrated, infection propagates here. But if it starts ascending, if ascension comes in, it goes into the kidneys and cause pyelonephritis. And next on, it can also lead to acute kidney injury in which there's too much destruction, there's too much tubular obstruction, and it might lead to sepsis. Now, this is the pathogenesis. How these organisms get there, they colonize, they ascend, they get into the bladder. After getting into the bladder, what they do? They penetrate the uroepithelium. Afterwards, they ascend towards the kidneys. And in the kidneys, they cause pyelonephritis, or in some cases, it can also cause acute kidney injury. Next on, we have diagnostic tools of acute onset of urinary symptoms. How do we diagnose a patient? For example, a patient just developed UTI. What's going to be the acute onset of urinary symptoms? First of all, toilet. We're going to talk about risk factors. We're going to talk about if she's pregnant. What risk factors we talked about? That whether it's a child, whether it's immunocompromised, whether it's taking any kind of drugs which suppress its immunity, whether it's pregnant. We're going to talk about all of these factors. If risk factors are not present, if the patient is not pregnant, we'll think about it that it's going to be uncomplicated cystitis. If the patient is just having these pains in the toilet, if the patient has burning micturition in the toilet only and there are no other symptoms, it's going to be uncomplicated cystitis. So what do? We go for the management, but before that, in the management, we give the patient no urine cultures. We don't ask the patient to go for urine cultures or other kind of tests because we know it's uncomplicated cystitis and it's going to get managed by the treatment. And even in the treatment, we ask the patient to take lots and lots of water and not much of antibiotics. There's no role of more and more antibiotics, but in some cases, we do prescribe them. We tell the patient on the telephone, we tell the patient about all the management, that the patient has to be very careful, has to be very hygienic, has to take lots and lots of water, and in some cases we do prescribe them antibiotics and we do prescribe them some alkylating agents. Next on, if the patient is having all of these problems and in the history of the patient risk factors are positive, those risk factors we just talked about, that whether it's taking immunocompromising drugs, whether it's immunocompromised already, whether it's suffering from systemic disease of some kind like diabetes mellitus, or the patient is pregnant, or the patient has unclear history, what we do, we think about it that it's going to be uncomplicated cystitis or STD. So we have to rule out uncomplicated cystitis or STD. So what do? We go for dipstick, it is called urine dipstick, which will tell us the pH of the urine, that will help us analyze what condition the patient is suffering from. Next one, we'll go for urine analysis, which will tell us what structures are found in the urine. It can be white blood cells, it can be pus cells, it can be anything. We'll go for it. In some cases, even the yeast can be found in your urine. So we'll go for urine analysis so that we might get the idea that what the urine of that patient is containing. What's the pH of that urine? Next one, we'll go for the culture, obviously, because we are confused between sexually transmitted disease, STD, and uncomplicated cystitis. So we have to be sure what organism is causing this disease, and on the basis of that organism, we'll know whether it's uncomplicated cystitis or it's sexually transmitted disease of some kind. Next one, we have STD evaluation. We'll ask the patient to come over. We'll do the whole examination of the patient. We'll do some tests. We'll know whether the patient is suffering from STD or not. Next one, we're going to go for pelvic exam of the patient so that we might get the idea whether the problem lies in the whether the problem lies regarding STD or uncomplicated cystitis. Next on, what happens if the patient has a history of perineal pain, whether the patient has a history of prostatic pain or has a history of pelvic pain. We think of what? We think of acute prostatitis, and it's going to be a male patient. So a male patient will present to you with these three symptoms. Either one of them can be there and maybe other two symptoms are not there yet, but they're going to get there. So you have to ask for any perineal pain, you have to ask for any prostatic pain, or you have to ask for any pelvic pain. If the patient says, yes, I have all of these pains, so you will think immediately that it's suffering from acute prostatitis. So what do? You go for urine analysis like before, you go for the culture, and you go for the urology. After all of this, you will manage the patient. Next on, among that, what's going to be the symptom? What are the symptoms that the patient will be presenting to you with on acute onset of cystitis symptoms? Right? Now we have cystitis symptoms. So it's going to be with fever, back pain, and nausea and vomiting. NV stands for nausea and vomiting. You will hear about a lot of nausea and vomiting. So for your convenience, we write N/V. It's nausea and vomiting. So acute onset of cystitis symptoms are fever, back pain, nausea, and vomiting. Otherwise, the patient is going to be healthy woman and it's going to be non-pregnant. That's why it's called uncomplicated pyelonephritis. So you'll go for what? Urine culture, you'll go for outpatient management. You don't have to admit the patient because it's uncomplicated pyelonephritis or cystitis, and it depends upon the pathology, it depends upon the symptoms. So in these symptoms with back pain, with fever, with nausea and vomiting, otherwise healthy patient, and it's women and it's non-pregnant, you will immediately think of uncomplicated pyelonephritis, and then you'll go for urine culture and outpatient management. Why urine culture? So that you might get the idea what organism is causing this uncomplicated pyelonephritis. So you specifically treat the that organism by specific antibiotics. All the other patients is going to be pyelonephritis. It's not going to be uncomplicated pyelonephritis. Uh, maybe it's pregnant women, maybe it's children, maybe it's immunocompromised patient, maybe it's suffering from diabetes mellitus. So it will be pyelonephritis, and you will go for urine cultures, you'll go for the blood cultures, whether the patient has got sepsis or not, whether the hematogenous spread is happening or not, and then you will manage the patient. Now let's talk about diagnostic. In the diagnostic tool, let's talk about non-localizing systemic symptoms. For example, the patient has leukocytosis. Maybe the patient has altered mental status. Maybe the patient has fever. Now, all of these are not because of urinary cause, but because of what? We'll think about. It can be UTI, COTI, or pyelonephritis. And those symptoms have propagated. They have involved a systemic manifestations. They have chosen the hematogenous spread. So you'll go for urine culture, you'll go for blood culture, you'll go for exchange or remove of catheter if the patient is having that catheter, if the patient is catheterized because of any disease, because of any other pathology that he was suffering from. So you will remove the catheter or change the catheter because it's a basic risk factor for getting the UTIs. Next on, let's talk about patient has got positive culture with no symptom. So what will you do? We have no urinary or systemic symptom related to UTI, but it's pregnant, a renal transplant recipient, or invasive urologic procedure. What do you do? Consider asymptomatic bacteriuria. And it's going to go for screening and treatment warranted. What if the patient is with urinary catheter? You will consider CAASB and you will remove that catheter or change that catheter, and no additional workup or treatment is required, and remove that unnecessary catheter we just talked about. Next on, all the other patients, consider asymptomatic bacteriuria and no additional workup or treatment is required even in these cases. Next on, we have diagnostic. In the diagnostic tools, we have recurrent acute urinary symptoms. So what are those symptoms? Recurrent cystitis will come to you again and again. This woman is suffering from recurrent cystitis. So you will go for what? Urine cultures, you'll go for prophylaxis, you'll go for patient-initiated management. What is the prophylaxis? We'll give them prophylactory antibiotics for those organisms which might be the cause of this recurrent infection in those patients. What's going to be patient-initiated management? Patient will be asked to do all of those things like keeping himself hygiene, keeping himself clear of all these factors, keeping herself healthy, eating healthy, and the environment of that washroom, of the toilet should be clean. It should not contain pathogens. The toilet seat must be covered properly. The toilet seat must be clean. All of these factors are very much responsible for causing the recurrent UTIs. So you'll ask the patient to take care of these things, and that's called patient-initiated management. And it also includes those antibiotics which will give prophylactically. So the patient will start this management on its own. That can also be included in patient-initiated management. On the other hand, we have chronic bacterial prostatitis. In this, what investigations we'll go for? We'll go for Mirez STEMI 4 glass test and urology consult. So you'll consult a urologist, you'll consult in the urology department, and you'll go for this test that will help us in getting to know what the basic reason of getting chronic bacterial prostatitis is. Next on, we have the treatments. So we'll start by telling you that what's the treatment of asymptomatic bacteriuria. Now, maybe many of you have gotten UTIs over the years, but won't even know about it because the immunity takes care of it. But if a patient gets a UTI for first or second time, we ask the patient to be very hygienic, to be very clean, to be taking lots and lots of waters, to be taking some of the drugs which alkylate the urine, so that it might decrease the pain which they endure during micturition. On the other hand, if it's the patient is suffering from uncomplicated cystitis and the patient is women. Why it's going to be women? Basically, it's going to be women because of the low size of urethra. I've told you multiple times, you have to keep it in your mind that it's 4 centimeter versus 25 centimeter of male. So 4 centimeters is a very small size of urethra, so any organism can easily get up to those 4 centimeters and infect your bladder. So uncomplicated cystitis in women is going to be treated with what? First of all, we're going to give them TMP SMX. What is TMP SMX? TMP stands for trimethoprim. SMX stands for sulfamethoxazole. So we're going to give it 1 tablet BG, meaning twice a day for 3 days. Or we can go for beta-lactams. Dose varies by the agent. 5 to 7 day regimen is given. Next on, we can give fluoroquinolones. Dose vary by the agent and it's also a 3-day regimen. Next on, we have pivmecillinum and it's going to be 400 milligram BG, meaning it's going to be given twice after every 12 hours for 3 to 7 days. Next, we have phosphomycin and it's going to be 3 grams single dose sachet. It's not going to be a 3-day regimen or 5-day regimen. So if it's uncomplicated cystitis in a woman, you can give any one of them. What's the deciding factor that which treatment or which modality you will go for? Culture. Culture can be the reason. Culture can tell you what organism is the causative in this case of UTI. So you'll go for specifically that organism, you'll go for specific treatment of that organism. You might be interested in treating the other two, but you will be pinpointing that organism to kill that organism so that the patient might get better. So you will choose an antibiotic which is specific for that organism so that you can treat the patient as early as possible. Next on, we have also nitrofurantoin, which is given 100 milligram twice after every 12 or 5 to 7 days. So these are the drug regimens which can be given in a patient, specifically women, if she is suffering from cystitis. And even in recurrent cystitis, we give the same treatment. Next on, we have a treatment of pyelonephritis. We talked about what pyelonephritis is. If the ascension of that organism has finally reached up to the level of kidneys, and kidneys are being affected, their tubules are being affected, they're being blocked. What's that called? It's called pyelonephritis. What's the treatment of pyelonephritis? It's going to be fluoroquinolones. Before I tell you the treatment of pyelonephritis, main, or you can say the major gender which gets affected or which gets pyelonephritis are females because of that short urethra. So we go for the fluoroquinolones, we go for oral ciprofloxacin with or without an initial IV 400 milligram dose. Now, what is that initial IV 400 milligram dose? It's loading dose. Some practitioner prefer that before starting the oral ciprofloxacin, we give the patient an IV dose, that's loading dose, so that the effect might be as early as possible. If we start with the oral ciprofloxacin, it will take some time to get its fixed dose inside the body and then start acting. So you start with IV antibiotic, IV ciprofloxacin 400 milligram, and then you go for the oral ciprofloxacin. So that up till oral ciprofloxacin kicks in, IV ciprofloxacin takes over the charge and treat the infection. Next on, we have oral TMP SMX, which is, we just talked about oral trimethoprim and sulfamethoxazole. Next on, we have initial IV dose of ceftriaxone. Now, just like initial IV dose of 400 milligram dose of ciprofloxacin, it's not a whole treatment. It's not a PET treatment that this is going to be just 1 gram dose of ceftriaxone. No, it's just an initial dose. You can start ceftriaxone orally afterwards. So initial IV 1 gram dose of ceftriaxone is given. Next one, if it's UTI in a pregnant woman, now what's the treatment? Now it's going to be tricky because it depends. You'll go for the cultures, you'll go for all the factors that are responsible. First, you'll try to eliminate those factors. First, you'll try to eliminate those risk factors. Then you'll go for the treatment. And in the treatment, multiple drugs have a very harmful effect on a pregnant woman, either on the baby or on the health of the women. So you go for only specific groups of antibiotics in pregnant women which is suffering from UTI. So you go for nitrofurantoin, you go for ampicillin, and you go for cephalosporins. Now these three groups are very safe. These three groups are safe for pregnant women who get UTI. Even in the recurrent UTIs, we only stick to these antibiotics. We go for the cultures, we try to find the basic organism which is causing that, and we might try to treat that, but basically we stick to these three groups of antibiotics which are responsible for treating major cases of UTIs in the pregnant women. Next on we have treatment of UTI in men. Now the treatment of UTI in men is very different because in men it's going to be prostatitis, or it's going to be cystitis or urethritis. Many of the cases are filled with prostatitis and urethritis. Some cases get cystitis, and in very few we get the complication of pyelonephritis. So what's going to be the treatment plan for a man who just got UTI? First of all, a 7 to 14 day course of fluoroquinolones or trimethoprim sulfamethoxazole. Next on we have complicated UTI treatment, which will involve emphysematous pyelonephritis. It's going to be percutaneous drainage. So in complicated UTI treatment, when we talk about emphysematous pyelonephritis, meaning the kidneys are being destroyed, the kidneys are being affected, and the pus is being produced. So what we do percutaneous drainage. As you can see, this is a patient that is suffering from this pathology. So what we do, we drain the pus, we percutaneously drain it. As you can see, we take out the catheter. First of all, we drain all the pus that is there, and then we band the place over the stoma site. We put a bandage over the place over the stoma site. Next on we go for the cleaning of the stoma and skin and around it and moving away from the stoma. You will start from the center of the stoma. After removing it, you will start from the center of the stoma and start moving outwards, right? That's how you clean a stoma. Now stoma is an opening opening which connects you to the interior of the body, to the interior structures of the body. Now, once bandage is to be placed over, once you remove the old bandage, you percutaneously drained it and then clean the stoma site and skin around it, you'll go for the antibiotics afterwards, right? And those antibiotics will be judged on the basis of culture results, that what organism is basically causing that. So you'll treat that organism, you'll go for those antibiotics. Now let's talk about xanthogranulomatous pyelonephritis. So in this xanthogranulomatous pyelonephritis, the treatment of this complicated UTI is going to be nephrectomy. Nephrectomy meaning kidney, adrenal glands, and the ureter is removed. All of these are altogether removed because there is no treatment of it. Because the kidneys and the ureters and those adrenals are destroyed up to such extent that there is no treatment of it. So what you do, you go for nephrectomy. You totally remove it. Why? Why we can't treat it? Because there's a much bigger chance of getting the sepsis out of it. There's much bigger chance of getting the sepsis and other systemic involvements out of it. That's why we go for nephrectomy in xanthogranulomatous pyelonephritis. Next on we have treatment of asymptomatic bacteriuria. We just talked about in major cases it's going to be asymptomatic bacteriuria. So how do we treat the patient of asymptomatic bacteriuria? First of all, if the patient has this catheter, we remove the catheter, we change the catheter. There's only two options. Either we remove the catheter or we change the catheter. Or what you can do is a push of saline. A push of saline will even help. And otherwise, there's no proper treatment of asymptomatic bacteriuria. Next on, we have treatment of catheter-associated UTIs. We just talked about those patients which have the catheter inserted inside them, which have the catheterization done, have much bigger chance of getting the UTIs. So what's going to be the treatment about? It's empirical treatment, mild to moderate, which will involve ciprofloxacin, levofloxacin, and ceftriaxone. On the other hand, in the severe infection, what we go for is cefepime. So even the catheterized patients have to be classified whether they are having this UTI on mild to moderate base or on severe base. If it's mild to moderate, you give these three drugs: ciprofloxacin, levofloxacin, and ceftriaxone. And if it's severe, it's going to be cefepime, ceftazidime, imipenem, and doripenem. Now, these are the antibiotics which are given if the patient is suffering from severe kind of catheter-associated UTIs. And meropenem is also given alongside them, right? So, in mild to moderate, you give ciprofloxacin, levofloxacin, and ceftriaxone. In the severe cases, we have these 5 groups. We can give cefepime, we can give ceftazidime, we can give imipenem, doripenem, and meropenem. So that's how the catheter-associated UTIs are treated. But before we treat catheter-associated UTI, you have to remove that catheter up till the point the patient is cured of this pathology, of this disease. Or the least you can do is change the catheter. Now, piperacillin and tazobactam are very rarely given, but when all of these are not working, and if the culture comes positive for these kind of for these antibiotics which cover specific organism and those are responsible, piperacillin and tazobactam are given together. Next on we have treatment of candiduria. Now, what is candiduria? Candiduria is if you have presence of yeast inside your urine. It means some kind of mold is there. It means it's a fungal infection. How do you treat a fungal infection? So the treatment of the fungal infection is going to be fluconazole, which is going to be given in 200 to 400 milligram per day for 14 days. So that's all for today. In this lecture, we learned about all the cases of UTIs. We learned about the risk factors which are responsible for causing the UTI. We learned about the organisms which are responsible for causing UTIs, for causing uncomplicated UTIs. We talked about the organisms which cause complicated UTIs. We talked about the organisms which cause recurrent UTIs. So all of these factors combined, all of these risk factors and organisms combined, we get the gist, we get the idea of what's responsible, what's the basic cause of that patient of getting UTIs. And we've talked about that female ratio is going to be much more higher than the male ratio. It's more than 50 folds because of their short urethra size. It's going to be in your exam. You have to remember that women tend to get more UTIs rather than men because of their short urethra. Now, next on, we talked about that how you have to approach the patient. How you have to approach the patient, you have to, first of all, you have to exclude the major risk factors. And those major risk factors were pregnancy, diabetes mellitus, or any other systemic disease which lowers your defenses, immunocompromised state, immunosuppressant drugs, or being a child. When all of these 5 risk factors are excluded, then you go for the normal treatment. Then you go for the regime of 3 to 4 days or 4 to 5 days, and then you don't go for examinations, then you don't go for cultures. You just go for the telephonic management and you tell them that you have to take care of yourself, you have to be hygienic, you have to take these antibiotics, and you will be fine. And you don't have to do anything else than that. But if it's complicated UTI, if it's have any of those risk factors, if it's a child or if it's a pregnant woman, you have to be very cautious. Now you have to call in the patient, you have to do the exam, you have to just divide between, you have to put a line between STD and cystitis, STD and these UTIs. First you have done that, next you go for the urinary cultures, next you go for the blood cultures, so that you might get the idea which organism is causing this UTI and whether that organism has get to the kidneys and got the hematogen spread or it was because of the lower spread. Once you have decided that, then you decide which kind of antibiotic you'll go for. We talked about what men will be taking: fluoroquinolones, sulfamethoxazole, and trimethoprim. Now, basically, they get these two groups of antibiotics. On the other hand, we talked about that cystitis, which is recurrent in women, which is major pathology, even among the UTIs. We go for 5 different groups and nitrofurantoin alongside with them. Next on, we talked about the pregnant women getting the UTI. We talked about only 3 groups of drugs are safe for them to use. So those 3 groups of drugs are given to the pregnant women. So that's how you develop this whole idea in your brain. First, you go for the history, then you go for the diagnostic modalities, then you take out the risk factors, whether they are there or not. Then you decide that whether you're going to go for the blood cultures and the urine cultures, and then you go for the treatment. That's how you treat our patients suffering from UTI. Now, that's all for today. Thank you for watching sqadia.com.